Hi, everyone. Thank you for joining us for today's webinar, Long COVID, What is it and what are the implications for patients and health systems? Today's webinar is being presented by the Veterans Research and Education Foundation with extra help from the National Association of Veterans Research and Education Foundations. VREF is a nonprofit foundation that helps fund research studies at the St. Louis VA. My name is Rebecca Kammer, and I'm the Director of Communications for the foundation. Today's presenter will be Dr. Ziyad Al-Aly. Dr. Ali is the Chief of Research and Development Service at the VA St. Louis Healthcare System. He is a physician scientist with broad research interests including public health, global health, environmental epidemiology, and pharmacoepidemiology. He leads several research initiatives aimed at developing a deep understanding of short and long-term effects of COVID-19 on health outcomes. He has published extensively in several major business journals, including BMJ, JAMA, Lancet, NEJM, Nature, and others. His work is frequently featured in major national and international media outlets, including the New York Times, CNN, BBC, NPR, The Guardian, Bloomberg, The New Yorker, The Atlantic, and several others. Today's presentation should be around 35 to 40 minutes, followed by Q&A. Please insert your Q&As in the chat box to the right of your screen. And at this time, I'm going to hand the floor over to Dr. Ali, who will be talking about the topics of his paper.
Well, thank you for having me, Becca, and thank you for the introduction. And thank you for the foundation, for the Veterans Research and Education Foundation of St. Louis and the National Veteran Research and Foundation and nationally for sponsoring this event. Thank you very much. So in terms of disclosures for this talk, I have no conflict of interest. And then the opinion expressed in this presentation do not represent the views of the U.S. Department of Veterans Affairs or the U.S. government. So what I want to talk to you about today is that what led us to study long COVID. Why did we decide as a group of researchers here at the St. Louis VA to study long COVID? We talk a little bit about what is long COVID, what do we know so far about long COVID, primarily focusing on our studies from the VA, and talk a little bit about the implications for health systems and communities. So first of all, like a little bit of a story here, like what led us to study long COVID, and really it's sort of the genesis of all of this came early in the pandemic when we had several brainstorming sessions in our team, asking the questions, how do we as clinical epidemiologists do our part, in helping the nation address the public health crisis that is COVID. And then, I myself as a physician, I'm a physician. I, went to the front line and helped there. But several of our members are biostatisticians and clinical epidemiologists. And then clearly the answer at that point was that what we do best. We identify knowledge gaps that are really important for the public to know, important for policymakers to really know, and then we address them. And then we sort of went on this journey of really leveraging our knowledge and energy and the resources that are available to us to address what we think are critical knowledge gaps that really would be helpful in advancing our understanding and fight against COVID-19 in the US and globally. And really the genesis of the idea of thinking about long COVID came very early to us, actually from initially in an op-ed piece that was published in April 2020 by a wonderful patient who told her story in this op-ed piece, saying she was young and healthy, doing very well prior to COVID. She got COVID, and weeks afterwards, she still had lingering symptoms. She had fatigue, she had shortness of breath, she had cough, and that told us that, although anecdotal, although it's an N equal 1, told us there was maybe something there that is sort of that COVID maybe is in some people is resulting in longer term manifestations. And to her credit, this op-ed piece really generated a lot of interest from patients and patient groups, and really they coalesced around her and formed what we now term or call is really the patient-led collaborative to study long COVID. And really, kudos to patient advocacy. This is a grassroots from patients and and people who got COVID and didn't recover from it, and they organized their own survey early on. This is really very early in the pandemic, in May 2020, telling us, among 600 respondents, that there's really a good share of them, a good percentage of them, are experiencing lingering symptoms weeks after the initial infection. And that told me and told our group that this really isn't anecdotal, isn't an N equal 1 or an N equal 2 or 3 people. These are hundreds of people, albeit it's not a control study, it's a survey, and it's subject to a lot of biases, but it really gives you a bit of an early indication that COVID itself isn't really, in some people, is carrying long-term consequences. And so and then that report itself and that effort sort of even blossomed even more to become what we call now a movement of long haulers, and they call themselves long haulers. They termed they coined the term long haulers, and they actually even came up with a name for the disease, long COVID. The NIH did not do that. The CDC did not do that. This term came from patients themselves, characterizing their lingering weakness, fatigue, brain fog, muscle pain, other manifestations as long COVID, and then calling themselves long haulers. So really, this will go down in the history of science and history of medicine as really an important episode where patients and patient activism and patient advocacy and the voice of the patients really galvanize a community of scientists to really study this problem. And I have to say up front, even from the beginning of my talk, like we wouldn't be doing this had it not been for these patient-led groups who really inspired us and told us that long COVID is there, exists, and really demands attention from people like us to really study it and solve problems and address knowledge gaps related to long COVID. So we asked the question, given these reports and given these anecdotes and these surveys, so what is long COVID? And at that time, we realized that really there was not a whole lot of information available to us to even build the hypothesis. Many of the people on the call will know that you have to have a set of facts to even build the hypothesis, to build the research question and build the hypothesis. So we had a question: what is long COVID? What simple question? What is long COVID? What are the long-term consequences or long-term manifestations of COVID? But we didn't really have a robust hypothesis because there wasn't really much known at that time. So we resorted to really doing a high-dimensional evaluation or a high-dimensional systemic evaluation. We literally wanted to leave no stone unturned. We wanted to start with an unbiased approach, asking the question, what is long COVID? And look at all organ systems and evaluate, vis-a-vis a control group, what happens to people who survive the first 30 days of COVID. And that's really the work that is, we will feature in this presentation. So what we found is that long COVID really can affect nearly every organ system. And we'll go through them one by one. And we found that long COVID can lead to mental health consequences, and that is increased risk of anxiety, increased risk of depression, sleep problems, substance abuse, increased risk of nervous system disorders, including strokes, headaches, memory problems, smell problems. There is clearly a metabolic component to long COVID. We see very, very clearly, although I was myself skeptical at the beginning, but we see a very, very clearly increased risk of obesity. That's an excessive control group, diabetes, and also hyperlipidemia. We clearly see also GI manifestations or gastrointestinal manifestations in the form of constipation, diarrhea, acid reflux disease. There's skin disorders, including hair loss and skin rash, coagulation disorders. That happens in the acute phase and also happens in 30-day survivors in the post-acute phase, weeks or months down the road, in terms of blood clots, sometimes in the lung and sometimes in the veins of the legs. Cardiovascular consequences or heart consequences, including acute coronary disease, heart failure, palpitations, arrhythmias, respiratory system problems, including cough, shortness of breath, low blood oxygen, kidney problems, including acute kidney injury, chronic kidney disease, musculoskeletal problems, joint pain, muscle weakness, and general problems, including malaise and fatigue. And you can see from this slide, long COVID can affect nearly every organ system. There isn't really, there isn't really an organ system where we looked and the risk was actually lower than the control group. And that's really, profoundly important, we think. And then we wanted to do a comparative evaluation. We've known all along that seasonal influenza is another respiratory virus, and we actually have known for quite a while that some people with seasonal influenza do not fully recover after the acute episode, after the first 3 or 4 weeks. So we wanted to do a comparative evaluation and see what would happen post-acute and in the post-acute phase in people who got infected with COVID-19 versus people who were hospitalized for seasonal influenza. And we observed two main findings, or two key findings. In the magnitude of risk, in terms of long-term consequences is much, much higher in COVID versus seasonal influenza. And then the breadth of organ manifestations is much more extensive. So two key things that told us that post-COVID syndrome or post-COVID clinical manifestations are radically different than what you observe with post-seasonal influenza, both in terms of magnitude of risk. The magnitude of risk is substantially higher and more pronounced, and the breadth of organ manifestations is much, much more extensive. So we conclude that this is really a different kind of post-viral syndrome. Post-viral syndrome is not a new entity. This is not a novel way of thinking. A lot of viruses, including seasonal influenza, sometimes produce post-viral sequelae and post-viral consequences. What we see with COVID is really substantially higher risk and much more extensive organ system manifestations. The risk was evident even among non-hospitalized, and that's really profoundly important, we think, because that's really the lion's share. That's really the majority of people with COVID. The majority of people with COVID in the United States and also globally did not get hospitalized for it. The majority of people nursed their COVID at home and got better, quote unquote, in 2, 3, 4 weeks. But then we see not a small portion of them go on to experience long-term manifestations or long-term consequences related to the acute COVID infection itself. We also saw that the risk increased according to the severity of the acute infection, and that the risk was evident and clear in people who were non-hospitalized for COVID, but then increased in people who were hospitalized and was highest in people who were admitted to intensive care for COVID-19. And I have to say that there was quite a bit of press on a study that was recently published by Fair Health, although uncontrolled, but it gives us a little bit of a glimpse of what happens in the post-COVID era or in the post-COVID phase or the post-acute COVID phase in a lot of patients. This is nearly 2 million patients reporting several symptoms, including pain problems, breathing difficulty, hyperlipidemia, hypertension, anxiety, intestinal issues, skin disorders, et cetera, et cetera, et cetera. Very aligned with our study, albeit our study was controlled specifically to really isolate the consequences that are attributable to COVID itself and not sort of really any background noise. There are several sequelae that are of concerns to us that we think really demand greater attention from the public, and I think always I like to sort of elaborate a little bit more on them. And we see higher risk of mental health disorders. That is in excess of what we observe in the control group. And that's really important because all of us went through a pandemic, and actually we're still in a pandemic, still at the tail end of it. And there is a really increase in rates of depression and anxiety due to loneliness and other factors. But we see that much more pronounced in people who had COVID itself. And so we think that really demands greater attention now, so it doesn't really balloon into a mental health crisis down the road, or even worse, a suicide crisis down the road. We also see increased risk of opioid use. As I said, pain is really a cardinal manifestation of a lot of people with post-COVID syndrome. And some of this is being treated with opioids. And I think it's very important to pay attention to this now before it really balloons into an opioid crisis down the road. There's clearly a cardiovascular disorder signature there in post-COVID. The concerning thing about these sequelae or these consequences, and these tend to be chronic manifestations that do not resolve with time and do not get better with time. And we think that really will contribute to a rise in non-communicable diseases down the road. Equally, we see nervous system and neurocognitive disorders, and we think will have ramifications down the road, and metabolic consequences. And we stress upon this diabetes, which we think is really quite an important finding, and it has been corroborated by multiple other studies independently evaluating risk of diabetes in people with post-COVID syndrome. So you should be asking now, gee, like how can a respiratory virus How can a lung virus or respiratory virus lead to so many disturbances in so many organ systems? And there's really no clear answer to this. There are hypotheses, and we'll share with you one slide and a conceptual framework of what sort of like the thinking about this at this point. SARS-CoV-2, or the virus that is responsible for COVID-19, attaches itself to a receptor that is actually present nearly ubiquitously on a lot of cells in the body, including lung cells, including brain cells, including heart cells, kidney cells, et cetera, et cetera, et cetera. And that doesn't really explain why with COVID or a respiratory virus really produce all these systemic manifestations, but it's really one of the clues that could ultimately lead us to better understand, why would a respiratory virus lead to these consequences. And then we have a little bit of a conceptual framework to sort of like think broadly about this. So we think about long COVID, we think about, there are likely, manifestations that are related to the virus itself. That is the virus properties itself, and maybe different variants will produce different phenotypes in long COVID. And then immune response to it. I mean, the host immune response to the virus itself might also lead to some sequelae in there, like disorders of autoimmunity or hyperactivation of the immune system. There are a lot of theories there. But not to be discounted, we think, is there's an indirect pathway here, and that the infection with COVID-19 in the context of a pandemic, really with all the attendant consequences in terms of a loss of employment, reduced social contact, changes in dietary habits, changes in physical activity, and other stressors, including trauma, grief, environmental stressors, et cetera, those may lead to either amplification of baseline conditions, as maybe subclinical diabetes not became evident, as a result of all these stressors, or emergence of new conditions. And then last but not least, there is a third potential pathway, is that a lot of patients, when they get COVID, they get actually medical care. And then it's very likely, although not really applicable in our study because we mitigated against this, but it's very likely that some patients will have unrealized conditions that are realized as a consequence of the intensity of care that they're getting in the context of having COVID-19. They get COVID-19, they go to the doctor checks some blood work, boom, they have high blood pressure, or they have diabetes, or they have high cholesterol. So those are not things necessarily that are related, or not necessarily that are provoked directly by the infection, by COVID itself, but maybe as a consequence of interaction with the healthcare system, they are subsequently discovered. So this really needs a bit of thinking down the road by us and a lot of groups, but I just wanted to sort of give you a little bit of our thinking about what are sort of the potential pathways that could explain this. Now, in terms of impact on the U.S. healthcare system and the world, like we think long COVID is really a serious problem, and we think it is America's next big health crisis. And this is really, again, it's another op-ed piece by Fiona Lowenstein and Hannah Davis in New York Times, saying that long COVID is not rare, it is a health crisis. They write, and I'm going to read because I think these words really illustrate or encapsulate really also what we think about this disease. A year later, we still struggle to be taken seriously. Few think that long COVID can happen to them or that it will affect their post-pandemic life. But long COVID is not a footnote to the pandemic or a curious human interest story. It is America's next big health crisis, and we should prepare for it now. And I think this is really, really quite important. That's because of the gravity of the sheer number of people affected with COVID. Even if a small number of them will go to experience long COVID, that's a huge burden on the healthcare system, and that's a really huge crisis that must be dealt with. And we think also that what we have been seeing so far and accounting for is really the tip of the iceberg. The toll of hospitalization and death, and then up till recently, more than 600,000 deaths in the United States. That is really the tip of the iceberg. Those deaths are attributable to acute COVID. What we think, when we start accounting comprehensively for the toll of COVID and include the post-COVID manifestations, that is, disease and disability from post-COVID, early mortality and its impact on life expectancy, economic implications and social implications, and global unrest, those will really, I think, will have subsequent ramifications, and it will really help us, see a little bit below the tip of the iceberg. So the CDC came up with guidance not so long ago, actually about a week ago, on evaluating and caring for patients with post-COVID. Here's a bit of a summary slides. The short of it is that many patients with post-COVID can be managed by primary care providers. Objective laboratory or imaging findings should not be used as a sole or only measure of assessment of patient well-being. Lack of laboratory or imaging abnormalities does not invalidate the existence of a patient's symptoms or conditions. And the guidance will likely change over time. So what are the implications for health systems? The burden of long COVID is likely substantial, as I said. Long COVID is a multifaceted disease that can affect nearly every organ system. We think it will be long COVID will result in a rise in burden of non-communicable diseases. We think of COVID as an accelerant of underlying conditions and will result in an emergence of new sequelae or new conditions. We think it's very important that governments and health systems prepare for the tide of patients in need of post-COVID care. The UK National Health System is already developing or already developed post-COVID clinics. Several systems throughout the VA healthcare systems actually already have post-COVID clinics. And several systems in the US are already offering post-COVID care and post-COVID clinics. Many post-COVID conditions can be managed by primary care providers with the incorporation of patient-centered approaches. Some patients will require multidisciplinary post-COVID care. And I have to admit that the optimal composition of post-COVID care clinics is not really clear at this point. What we think is that providers should be able to address respiratory, cardiometabolic, mental, and neurologic consequences. So in terms of implications for communities, best way to prevent COVID is to prevent long COVID is to prevent COVID through vaccination. And then there is a tide of misinformation and disinformation out there, and I think that should be combated not only by medical professionals but also by communities. And as I mentioned at the beginning, really the wonderful and beautiful role of advocacy of patients that really galvanized a community of researchers around long COVID, and really certainly inspired us to study this and to really take it on as a subject of intense interest in our group. So in summary, long COVID is a multifaceted disease. It can affect nearly every organ system. The burden of long COVID is evident even among non-hospitalized. And we think that's really important because that's really the majority. That's the lion's share of people with COVID in the US and globally. The burden of long COVID is increased with the severity of acute infection. Government and health systems must adapt quickly and establish post-COVID care strategies. And we think that's really very, very important. Last but not least, I really wanted to acknowledge all the people who really contributed to this work. Chiefly among my two co-authors on this Nature paper, Yan Shea, who's really an amazing individual who I had really the honor to work with, and Benjamin Bowe, who's really also amazing and has really worked diligently with us on this paper. Yan's grace is really what propelled us every step of the way, from A to Z, from the start line to the finish line of getting this work published. Other team members, including Miao Kai, Andrew Gibson, Evan Zhu, support from the US Department of Veterans Affairs, the Institute for Public Health at Washington University, the American Society of Nephrology. And then, as I said, also, it's very, very important, long haulers who inspired us and continue to inspire us to do this work. I run the research office at the St. Louis VA, and really I cannot do what I do without really the wonderful support by the administrative team of the Research and Development Office, including Susan Wood, Erin Olson, Todd Cliche, and many others. I couldn't really fit all their names here, but really their strong and steadfast support really what enabled me and enabled my team to do what we do. And the Medical Public Affairs at Washington University, who really spearheaded the effort to really publicize our work and make it known to the world. And last but not least, the Veterans Research and Education Foundation of St. Louis, including the Executive Director, Mary Coleman, and Alison Schaefer, and the NAVREF, Hawk Tran, and also Becca Camber, who really done an enormous job to really help put this together. So I want to make our pitch here. We're always interested in growing, and if you're interested in joining us, or you know somebody who might be interested in joining us, we're always hiring. We're interested in hiring postdocs and biostatisticians. Please email me directly at zalally@gmail.com. And with that, and my Twitter is @zalally. And with that, I'd be delighted to take questions from the audience.
Thank you, Dr. Ali, for your presentation. We have several questions that have been submitted. As a reminder, if you have a question you haven't submitted yet, please enter it in the chat box to the right, and we will get through as many as we can. Dr. Ali, the first question, what would you say was the most alarming thing you noticed while conducting your research?
Oh, thank you for that. That's really a very important question. So I think I said that in the slide. So really, we think there are several consequences of COVID that we think that demands attention, and we felt alarmed by them. A is really the mental health disorders, the rise or the increased risk of anxiety, depression, sleep problems. And we really think that really requires attention now, so we hopefully can prevent it from ballooning or cascading to a larger crisis down the road. What also we feel is really important and alarming is really the pain and also increased use of opioids among long haulers. And we think also that really demands attention. And last but not least, the cardiometabolic disorders, cardiac diseases, and metabolic diseases, including diabetes. So we think this really will contribute to increase in the burden of non-communicable diseases, just by the sheer number of people potentially affected with COVID and also long COVID. This will certainly, we do a lot of burden of disease assessment. So this will contribute to a rise in the burden of diseases, including burden of diabetes, cardiovascular disease, stroke, and other conditions. So, and we think that our message to the medical community that we certainly need to pay attention to post-COVID care and have post-COVID care strategies. So hopefully we can recognize these things early in the trajectory, and then mitigate them or address them so they don't balloon into larger crises down the road.
Thank you. And what can people do who have recovered from COVID to decrease their long-term effects they might suffer?
Oh, this is really sort of a broad question. I mean, so the people who recovered and don't have any sequelae, so that's really wonderful. And that's really the majority of people. So I have to say that while we're talking about long COVID, the majority of people with COVID will fully recover and go on to experience no problems down the road. However, for people who really are affected with COVID, I think we sort of think definitely checking with a primary care physician to make sure that those symptoms are evaluated and addressed early on is really the right way to go.
Is there any way to reverse the damage COVID has done to your body?
Oh, this is a great question. You guys are like wonderful. So, post-COVID or long COVID is really a multifaceted disease. And as I said, it can affect nearly every organ system. So we see a lot of sequelae, a lot of consequences of COVID that might actually get better with time. One could imagine like somebody with fatigue today or with weakness today, or maybe or brain fog today, that actually might improve with time. But we also see that metabolic consequences, heart damage, chronic kidney disease, and those things tend to last a lifetime. Those people who are affected with these chronic conditions as a result of in the post-COVID phase will likely bear the scars of this for a long time or for a lifetime. So there's no one single answer to this, because post-COVID or long COVID is a multifaceted disease. What makes it really hard to study, but also very, very interesting, it is a multifaceted disease. It's not a monolithic entity. It's not one thing. It's a multifaceted disease. It is not monolithic. And some manifestations or some consequences will likely improve with time, and some might be more long-term consequences that will be chronic.
Can long COVID affect people who were asymptomatic or only had mild symptoms when they had COVID?
So in our study, we didn't really address asymptomatic people because we didn't sort of have that sort of the level of detail. But it's now become very, very clear from really a wave of studies that even people who really were asymptomatic in the acute phase of the infection, that is the first 30 days, even people who got COVID didn't even know they got it or got COVID, but remained asymptomatic or had very, very mild infection at the beginning. Even those people, they're actually still prone to develop long COVID. Obviously, the risk is lower than those people who needed to be hospitalized, and is lower than those people who needed to be admitted to the intensive care unit for it. However, the risk is not zero. The risk is small in people who were asymptomatic during the acute phase, but it's not trivial and it's not zero.
Does the vaccine help you if you have long COVID?
Oh, this is another great question. So the short answer, we do not know conclusively that the vaccine actually helped ameliorate some symptoms. There are anecdotal observations. Those are really small studies or small reports from 1 or 2 or 3 patients. There is one single study of about less than 100 patients saying that following the administration of the vaccine, some patients reported improvement in post-COVID outcomes or post-COVID clinical manifestations. So I have to caution us that we don't have the definitive answer to this yet. And all what I just cited were anecdotal observations that are really small reports, 1 or 2 or 3 people recounting their story that they got COVID and they were tired and fatigued and weak. Then all of a sudden now they have their energy back. They feel energetic. They feel much better after getting the vaccine. And there is really one study over less than 100 patients. So the jury is still out. We don't know conclusively that this is really what that the vaccine actually ameliorate the post-COVID manifestations, and which ones. As I said, post-COVID is a lot of things. It's not one thing. It's not 2 things. It's really a broad set of manifestations in various organ systems. We don't know which ones are going to also be responsive to the vaccine, which ones are not.
Thank you. Could you talk more about the mental health issues that have arose with COVID?
Sure. So we saw, compared to a control group and equally weighted at baseline to really have the same probability of getting COVID. But basically, compared to a control group, we saw really higher risk of increased risk of anxiety, PTSD, depression, and sleep disturbances, and actually even intake of anxiolytics and antidepressants and sedatives or sleep aids. So that's really what we know at this point. We don't really know a whole lot more about sort of the mental health consequences of COVID. I have to say, though, that even in the control group, I mean, all of us went through a pandemic, and even those people who were not affected with COVID directly, who didn't get the infection, still lived through the pandemic and are now like beginning to realize sort of the toll of it on the mental health of Americans. Being at home and isolated from people, and maybe loss of employment or other and social isolation and other grief and other consequences might also lead to mental health toll. But what we've observed is really much higher, much more pronounced. The risk was much higher in the COVID group, in that the COVID patients are more prone to develop those consequences down the road. We think that deserves a lot more study, again, to better understand it now, and hopefully shine light on it and nip it in the bud, so before it really becomes or cascades down to a much more serious problem down the road.
Can you elaborate on how long COVID differs or is similar to other post-viral illnesses?
Oh, wow, this is another very good question. So we've known all along that a lot of viruses produce post-viral syndromes, and the one we know most about, or actually we characterize in our studies, is really what happens to people post-influenza. So what we've seen in post-COVID versus post-influenza is really a much higher risk in COVID, much higher risk of clinical manifestations or clinical problems in COVID versus influenza. And also the breadth of organ manifestation, the number of organs that are potentially affected is much, much more broad. I think shining light on post-COVID and understanding it better is going to already galvanize the community of chronic fatigue syndrome and other post-viral illnesses. And I think understanding the biology and the mechanisms by which COVID results in these post-acute clinical outcomes will hopefully elucidate or actually enhances our understanding of what's happening in post-viral illnesses. And hopefully, the hope is that this really will identify treatment opportunities that we can target patients or help patients with treatment options down the road.
Could you please talk about pain and opioids and the rising opioid epidemic caused by long COVID?
Oh, thank you for that. Again, we think that there is. We see pain in our study and a lot of other studies. We see that pain is a major manifestation of long COVID. People are reporting pain, and I think I have to say here that there is a tendency among some to sort of disregard this and say, well, it's all in your head, and we think we beg to differ. I think this is pain should be treated. We see signals in our data that compared to control groups, people with post-COVID, pain in post-COVID is being treated in some cases, not really a lot, but some, sufficiently alarming, but small but sufficiently alarming, with opioid. And I think that really the message should be out that pain is a manifestation of COVID. It should be treated, and it should be treated seriously. However, people should explore to the extent possible other pain medications, and leave opioids to be the medication of last resort. So opioids should be the medication of last resort. We're not saying here, I'm never going to say that pain should not be addressed and pain is not real and should not be treated. What we're saying here is that pain is real, and long COVID is real. Pain is real. It should be treated. However, it should be a lot of other modalities should be explored first before resorting to opioids, and opioids should be the medication of last resort.
There's been instances of people getting diabetes after having COVID. Is this something that might go away with time?
Oh, this is also another very good question. So the way we think about new onset diabetes was actually a little bit of a surprise to me. I sort of almost didn't believe it at the beginning that this really cannot be happening with COVID. Why would a viral, respiratory viral illness produce a phenotype, that includes metabolic consequences and new onset diabetes? I refused to believe it until my team had to convince me that the data is the data, and that's really the signal is there and strong, it's clear, repeatedly. So, but the generally diabetes or metabolic manifestations, those are really generally chronic manifestations. So diabetes itself might get better with time, but really the phenotype that actually produces a diabetic state or produces glucose intolerance and disturbances in insulin glucose homeostasis, once you have that derangement, it's really sort of hard to sort of rewind the clock and go back to a state where diabetes does not totally exist. So that's not to say that maybe vaccine, maybe other modalities might actually result in improvement in glycemic control. Maybe weight loss might improve glycemic control. So certainly there are things that need to be addressed there, and those might ameliorate the course of diabetes. But generally, the way we think about diabetes and sort of general wisdom about diabetes is that it's really is a chronic condition that is likely lasts for a long time.
If you could get one message out to everyone regarding COVID, what would it be?
I think I may be preaching to the choir here, but I think the most important thing is really to vaccinate as many people as possible, as fast as possible. And I think we've said this all along, but really the best way to prevent long COVID is to prevent COVID. And I have to say nobody is immune from long COVID. Long COVID can affect young people, it can affect old people, it can affect males, it can affect females, it can affect people who are healthy, it can affect people who really had poor health status at the beginning or before they got COVID. It really can affect anybody. So nobody is immune from long COVID. And the best way, the absolute best way to avoid long COVID is to avoid COVID through vaccination.
What should health systems do? Is there a best practice model for them to use?
I think at this point, our thinking about what's sort of the best way to really structure care and post-COVID care strategy is evolving. And I have to say that we have to be humble about what we know or what we don't know. And I think we don't really know what's the most optimal care strategy of post-COVID. What is really clearly evident to me and to a lot of us when we really think about this is that COVID or long COVID is a multifaceted disease. It's likely affecting a lot of people. What we think is that healthcare systems should be ready to deal with or to cope with this tide of patients with post-COVID. And they should really have at the ready post-COVID care strategies to really help deal with the long-term consequences of COVID. And then they should leverage the principles of learning healthcare systems. We will iterate and improve as evidence becomes available to us. And evidence will become available to us from our group and others. Evidence will become available over the next 6 months, year, 2 years. And I think systems should adapt and learn and iterate. But that's not an excuse not to start now, not to have a form and develop post-COVID care pathways to really help address the consequences of COVID in the many patients that are experiencing it.
Are there any common factors such as age, weight, among those who do get long COVID?
So this is a subject of study now. So I think we're being asked here, what are the risk factors of long COVID? I think we still don't really know, sort of what sort of really increases the risk of having long COVID. I think we're all learning about what long COVID is and learning about its risk factors. I think the jury is still out on that.
Thank you, Dr. Ali. And that's all the questions that I've received. Does anybody have any other questions they'd like to ask before we wrap everything up? If you do, you can enter it in the chat box to the right.
All right. All right, with that, well, thank you very much, everybody, for attending this. I'm going to hand it over back to Becca Canner.
Thank you, everyone who joined us for today's webinar and those that asked questions. Dr. Ali, we thank you for sharing your insight and expertise. If you have any additional questions or would like to connect directly with the VREF team, you can either reach out directly using the contact information on this slide, or you can reach out via Twitter or Facebook. Thank you for your time, everyone. Have a wonderful rest of your day.